So despite a lot of effort over the last 40 years since the publication of 3+7, nothing has been shown to be clearly better than that regimen for patients fit for chemotherapy. It induces remissions, and some of our patients are cured. The trouble is that remissions are only achieved in about 3/4 of young patients with intensive chemotherapy, but more importantly than that, the relapse rates are quite high, at least 50%, if not higher, for younger patients getting intensive induction chemotherapy 3+7 followed by post-remission high-dose cytarabine. So there's clearly a need for improving on those outcomes. Now recently there's been some data that suggests that if you not only achieve a remission morphologically under the microscope at day 28 after that intensive treatment, but if using a very sensitive assay you don't see any evidence of disease, for example by flow cytometry or next-gen sequencing techniques, that those patients who achieve those deeper remissions that we call minimal residual disease negative or MRD negative appear to do better. It correlates with better long-term outcomes. So the hypothesis is, can we add something to 3+7 that can induce that MRD negative state? Now we had done a phase 1 study with monotherapy with vadetuximab talarine, an antibody drug conjugate against CD33, and found actually not only remissions with that single agent, but MRD negative remissions. And so it made sense to add it to standard chemotherapy. So the study I presented on behalf of my colleagues was a phase 1b study, 42 patients who received 33A on day 1 and day 4 of the standard 3+7 induction. And then we assess response, and patients can go on to receive post-remission treatment at the discretion of the treating physician. We don't have much sequence data for mutational analysis on these patients. We know that a minority of these patients had nucleophosmin mutation, but also a minority had FLT3 mutation. However, there were patients with adverse risk karyotypes in this clinical trial, and still the complete remission rate was 60%, and the majority of those were complete remissions, 40%, and the other 20% were CR with incomplete platelet count recovery. Even in those patients, MRD negativity was achieved. So of course it's not a comparative study, it's not a randomized trial, but when you look at that data in the adverse risk group, I think there's reason to hope that it may actually deliver some benefit for those patients. It's going to be an interesting time. If I may, there are other drugs that are being developed in that space for secondary and treatment-related acute myeloid leukemia, and one, CPX-351, a liposomal encapsulation of cytarabine and daunorubicin in a 5-to-1 ratio, actually in a phase 3 study showed a survival benefit just in that population of patients compared to 3+7 chemotherapy. And so I think the landscape is shifting very rapidly, fortunately for our patients, but it means that we will now have to test other drugs in combination with CPX-351 in specifically that population of patients.